So yeah, as I said, the first couple of points are just some quick kind of updates. And then afterwards, I had an interesting recent case that was kind of a new clinical entity to me. So I thought and it is a bit and has applicability outside of neurology. So I thought I would share it. So we'll first talk about some recent changes to inpatient stroke care. Then a little blurb about anti-seizure medication and treatment of status epilepticus. There was a memo that came out recently about that. And then, as I say, the case presentation at the end. So about the stroke update. Big thing that the stroke service is doing this year is going through a process called stroke distinction. So that is something that's administered through Accreditation Canada, and it's basically it is sort of an award process to show the quality of the program, that it's committed to improvement. So there's an initial sort of achievement of the status, and then there's a process for maintaining it over future years. So the big part of it for this year is going to be an on-site survey. So in November of 2024, which is coming up quickly, there will be a multi-day on-site survey, basically, of the stroke services. A big part of what we're doing until then is going through a lot of key quality indicators. There are dozens. And making sure that we're tracking them properly, that we have the right data to show where we are in terms of standards in meeting these indicators, and coming up with strategies for improving them over time. And then another big part of the project is an innovation and excellence project. And so what we're doing for that is a cohorting strategy. So we have had great success with the integrated stroke unit opening 4 years ago, and it's achieved a lot in that time. But one of the main challenges we still have is that not all of the patients that present to SHN with stroke make it to the ISU, and they're not all treated there. And so we're looking at sort of ways we can try to get more patients the same kind of quality of care. So the cohorting project, this is kind of the idea of it and the proposed sort of timelines. This is from an earlier sort of planning slide, but if you can see on the left side, the first phase was to cohort stroke patients, so put them all in the same place. Starting in the first phase from patients that are arriving at the Birchmount Emergency Department and on Birchmount inpatient units having stroke. So if they're known to be a stroke unit, essentially candidate, but are either in the ED or have made their way onto another unit, then it's trying to get those patients, when the ISU is full and has no beds, onto 3D at Birchmount. And there are 6 beds set aside to be essentially acute stroke beds on 3D. And so that phase is the first phase. And then as that sort of gets underway and smoothened out, the next phase would be to take patients from all the EDs and all the inpatient units and try to move them onto that same cohorted unit on 3D. And then the third phase eventually would be to get all of those patients onto, if the ISU is full and if 3D is full, then to open up 5E at Centenary as the second cohorting unit with an additional 4 to 6 beds. And so that's the sort of longer term plan. This is the sort of, I guess, medium term plan in the interim while we try to expand the actual single dedicated ISU to capacity for the full size that it needs to accommodate all of those patients. That's going to need a bit more work in the immediate environment. So there was, some people might have seen there was a memo that came out a few weeks ago saying that they were basically announcing the first phase that I showed there in the last slide. So excited to share a development in stroke care delivery. that will be taking place. So started on June 5th. So we've been going actually a couple of weeks now with that first phase. And I think it's not everyone has been aware of it. So that's why I wanted to give a little update here. So basically, as mentioned, using 3D as the cohorting unit. So acute stroke patients that are not able to get to 4B when it's full, the ISU at 4B, moving to 3D. And then this is just a little sort of internal, just talking about roughly the sort of flow process for this. So a patient in the emergency department admitted for stroke, and then their flow coordinator is supposed to connect with the 4B charge nurse to notify that they have a patient that needs admission for the ISU. If they meet the criteria and are a good candidate, then they would try to go to 4B into the ISU. But if there is not a bed on 4B, then the next step would be to plan to admit to that cohorting unit on 3D. And then if 3D is at census or surged, then they would work to try to relocate a patient from 3D to another ward and move the stroke patient onto 3D, so that all the acute strokes could either be in the ISU or together at 3D, sort of following the principle that we know that geographic stroke units, keeping stroke patients physically together is beneficial for their care, acute care in hospital. So I just wanted to bring that to people's attention if they weren't aware of it. And so you may see more stroke patients on 3D. That's intentional. You may see, a group of them together, and that is intentional as a strategy for trying to kind of come up with an interim plan for improving the access to stroke unit. I asked Gemini Abraham, the manager for the stroke program in the ISU, to join us just in case. I know there's not too many people on the line, but if anybody has any questions about process or, the nuts and bolts of things, she is here just for a few minutes. So I'll just open it up now, I guess, to questions about, organizational sort of things about this program.
Thanks, Dr. Smith.
We'll give it a minute. If nobody has any questions, then you're free to get back to work at the unit.
No problem.
And
Thank
I'll move on. Nothing in the chat, nobody's hands up, so I think we're okay. So as I say, I'll try to, get this information disseminated in other ways, so that I'm on the Birchmount this week actually on call. So I've been seeing my medicine colleagues over there, try to get the word out. But thanks, Gemini, for joining me. And I think we're going to move on. All right, so my next, next topic. So I'd like to talk a little bit about, skipped ahead one there. Yeah, a little bit about IV anti-seizure medications. So this is another memo you might have seen lately, came out again a few weeks ago about IV levetiracetam. So with Susan John and our pharmacy colleagues, Loretta particularly, we have been looking at the use of IV levetiracetam, which has really gone up a lot in the last number of years. And I think I've definitely seen that. So much so that it's really quite notable for the cost that it's incurred to the system. Now the third highest drug use in medicine, only exceeded by dalteparin that everybody gets every night, and ceftriaxone, which is given an awful lot. So almost, over $177,000 last year in IV levetiracetam. So a few notes about the medicine. So levetiracetam, Keppra, is a great anti-seizure medicine. It is essentially 100% bioavailable. So if there's any way of getting oral levetiracetam into a patient, they will absorb it well. And And so that is something that we see, that patients that do have potentially or actually an enteral route are sometimes still on IV levetiracetam. So we're trying to make people sort of aware of that and think about it and switch them to an oral form as quickly as they can when they've been on IV levetiracetam. And then what I've really seen in the last few years is a huge shift away from phenytoin and towards levetiracetam as first-line treatment for status epilepticus, and sometimes not even status epilepticus, but maybe multiple seizures. Maybe a patient's had 2 or 3 seizures in the course of a day. And levetiracetam IV being used very frequently in that kind of scenario. So we tried to put forth just a memo to think about some of the other options that we have. So those include Dilantin, phenytoin, that I think most of us have been comfortable with using for a long time. We do also have IV lacosamide here at SHN on the formulary. Most of the time we'll use that as a sort of second, third line agent in status epilepticus, or sometimes for patients that are on lacosamide as outpatients and don't have an oral route. Valproic acid is not a particularly practical one for immediate use because it's not general, it's a special access sort of thing, and so you can't get it right away. So really it's not helpful. And then fosphenytoin is just used in pediatrics. And so on this memo, we also added a little bit about guidelines, just to say that, there aren't really any guidelines that say it's should be used first line over phenytoin, or there's a reason to do that. And I'm going to show a couple, just talk about a couple of those. And so at the end of the day, in this memo, the recommendation is to keep thinking about using IV phenytoin for status epilepticus. So, and actually to mention again, the benzodiazepines are obviously first line. So lorazepam or another benzodiazepine absolutely should be the first thing, and almost always is. But after that, IV phenytoin still a very efficacious medicine for treating status epilepticus. Some of the points in here, I thought, just raising what I think sometimes people consider when giving levetiracetam instead of phenytoin or something else, is that, thinking about keeping a patient. So it's true that in recent years and decades even, we have very much moved away from using phenytoin long-term for patients because of the long-term side effects. But treating somebody in status with a medication, they definitely don't need to stay on that same medication through the rest of their hospital stay, or when they go home from a hospital, or years after that. And so the suggestion is to use levetiracetam Keppra mainly in situations where phenytoin is not a good option. And so obviously an allergy, if you happen to have a level and they already have a full therapeutic level of phenytoin, then it's not really helpful to give them another load. And in the loading of phenytoin, I mean, the main adverse effect we worry about being circulatory sort of hypotension. And so with hemodynamic instability, it may be a better choice to use something else. And then again, to think about going back to the oral form as soon as possible if we are using IV Keppra. So just to go back there, unfortunately, aren't a lot of really recent, hopefully there will be some soon, guidelines for status epilepticus. But just to go back, I know this is almost 15 years old now, but the European Federation of Neurological Societies, EFNS, still have their preferred treatment for generalized status epilepticus as lorazepam, 4 to 8 milligrams, or diazepam, followed by phenytoin at 18 milligrams per kilogram, and then repeating another benzodiazepine dose, and then going to obviously other agents for third line and fourth line agents after that. And then the American American Epilepsy Society, AES, 2016 guidelines are a bit confusing, but generally they looked in their way of looking for evidence of are there guidelines they can give, and they sort of ask specific questions. So the answers to those questions they come down to IV lorazepam being more effective than IV phenytoin on its own. And I think we all know that benzodiazepines are absolutely the first thing to do. So you wouldn't give just phenytoin without benzodiazepines. No difference in efficacy between lorazepam followed by IV phenytoin, IV diazepam plus phenytoin followed by IV lorazepam, or IV phenobarb followed by IV phenytoin. So a number of odd combinations. I'm not sure why they chose to select those in particular. IV valproic acid, similar efficacy to phenytoin or continuous IV diazepam as a second-line therapy. As I mentioned, valproic acid is not really a viable choice for us because of access reasons. And then this is the 2016 guidelines still say insufficient data exists in adults about the efficacy of levetiracetam as either initial or second-line therapy. This is 2016, but it is levetiracetam was FDA approved in 1999, so it's 17 years after we had it available. I think that there is more. People do feel that I don't want to suggest that levetiracetam is not effective for status epilepticus. Not the message I'm trying to set out. I think that we generally feel that it is, and in pediatrics, I think the evidence is even stronger. However, just to say that there isn't information to say that it's better, more efficacious than phenytoin, and I think we should remember that because there's been a big switch. So just to remind people of the appropriate loading doses for phenytoin between 50, in those European guidelines was 18, but between 15 and 20 milligrams per kilogram. And I think that's well established in people's minds. They kind of have a good sense of that. Sometimes it gets kind of shortcutted to 1 gram, which is usually going to be not far off, fortunately, for most people. What we do see, unfortunately, is that sometimes that same shortcut gets applied to levetiracetam, and people get a 1 gram, 1,000 milligram loading dose of levetiracetam, which is really too little for status epilepticus. So if we're going to give it, it really should be 60 milligrams per kilogram up to a maximum of 4,500. So the dose is much higher than it is for phenytoin. I think we have to remember that because I think people sometimes go to IV levetiracetam and underdose it quite a lot. And then valproic acid, if you are using it, 40 milligrams per kilogram to a maximum of 3 grams. So I just wanted to bring that to people's attention that we have IV levetiracetam. In many cases, it is absolutely the most appropriate thing to use, but I don't want people to forget that Dilantin is still extremely effective as a medication at stopping status epilepticus, and I still think of it as my first option after a benzodiazepine. Okay, so that's the memos. And now I'm going to move on to a case that I'd seen recently. A number of the neurologists here saw. And it was interesting because as I say, learned something about a new clinical entity that I really didn't know a lot about before. So this was a 41-year-old lady who came into our emergency department. The triage note said she had a 1-day history of vomiting, had a history of lupus, and was having a flare-up, and hadn't really been able to ambulate for a week. And then fleshed out a bit in the emergency physician's note. She'd vomited 5 times since that morning, had had a bad headache since the previous day, was photophobic, felt dizzy, and described difficulty walking for about a month, so maybe a little bit longer even, these balance problems. On their examination, she showed very unstable gait, somewhat ataxic, no nystagmus, no diplopia, but slow, rapid alternating movements, a mild intention tremor, no facial droop, and I think there was a mention of no limb weakness either. This lady had indeed a past medical history of systemic lupus erythematosus for about 15 years at this point. Initially presented with joint involvement, had typical positive serologies for lupus, and had a number of flares in the past, including one with lupus nephritis, but she'd made a very good recovery from that. She also had some hypothyroidism. Her medications, mainly for her lupus, she was on azathioprine, 125 milligrams daily. She was on hydroxychloroquine, 200 milligrams twice a day, 5 days a week. And then at the point that she arrived, she was on prednisone, 5 milligrams daily. And that had been reduced just a few days before from 15 milligrams. And I think it had been increased some weeks before that because they weren't sure if these new symptoms she was having, the dizziness, these things could maybe be related to her lupus. And then a little dose of levothyroxine for hypothyroidism. Otherwise, a pretty healthy lady. She did not smoke. She very rarely drank any alcohol. She did not consume any recreational drugs. She had a little bit of recent travel. She'd been to Cancun in the previous December, but didn't feel like she'd had any problems following that. She did go to Las Vegas in February, and this presentation was May, so a couple months before, and had sort of symptoms of a minor upper respiratory tract infection in the Las Vegas trip. So then in talking to her, hearing, fleshing out the dizziness sort of story a little bit, she described it as sort of disequilibrium dizziness for about 3 months. She didn't really have vertigo. She didn't have a strong spinning feeling. She wasn't really nauseated much until the acute presentation where she had the vomiting. And I think that was a bit of a red herring. Oh, sorry. And then this dizziness really was slowly progressive since its onset. So over these couple of months, it just kind of seemed like it was getting worse. And then starting to really notice difficulty with walking, feeling unsteady for at least a few weeks, starting to sort of touch the walls as she walked. And then in the week or several days before her arrival in the emergency department, started to notice a little bit of trouble with her speech, getting a little bit of a slur and slowing down, finding it a bit hard to pronounce things properly. And in those same sort of few days, she started to notice some slight upper limb clumsiness as well. So mistyping, kind of hitting the wrong letter, having difficulty placing objects carefully. In terms of constitutional symptoms, she'd had a few kilograms of weight loss in the past several weeks, not that great an appetite, but no night sweats or fevers. And then she did actually have a long history of infrequent headaches that were totally consistent with migraines. And I do think that that's what caused the headache and the vomiting on the day that she sort of came in. There was a question about whether she might have vasculitis because of the headache and lupus history and that sort of thing. But really when it seemed like most of the new problem was really this subacute dizziness, and it really looked like a migraine on the day before she came in with a headache and vomiting. So when I saw her, she had quite intact mental status. She did have some subtle eye movement problems, hypometric saccades to each side laterally. She did certainly have a little bit of dysarthria. It wasn't a lot, but noticeable. And then she certainly had some dysmetria of her upper limbs, some dysmetria of her lower limbs, and was notably ataxic walking. Her initial CT head was really unremarkable. And although looking, I guess, carefully at the cerebellum, you could see some difference. And then her initial blood work, she had a mild pancytopenia, probably not too surprising with SLE. Not particularly high inflammatory markers. TSH was normal. Positive lupus serology, as mentioned, slightly low C3 and C4 complements, but nothing really kind of suggesting a raging inflammatory state. So the kind of overall picture at that point, 41-year-old woman with known SLE, with this subacute progressive kind of cerebellar syndrome. So we're thinking, could it be a manifestation of her SLE? Could it be vasculitis with the headache and sort of more dramatic presentation, but didn't really fit with the longer history? Could it be cerebritis? Similarly, not a profound inflammatory picture, but certainly with the headache and vomiting and whatnot, venous sinus thrombosis sort of comes into the thought. But actually, when her headache did resolve quite quickly, by the following day she was in hospital, she was really headache free, and so it seemed pretty unlikely that was the case. Certainly this couple of months of a new ataxia makes you think of a paraneoplastic or autoimmune cerebellar problem, other infectious or inflammatory causes of ataxia, or, potentially certainly in the ballpark of a metabolic kind of ataxia. So she had a lumbar puncture that was quite bland, normal white blood cells, no red blood cells, normal protein. Glucose was very slightly high, which didn't really mean too much. Eventually, the oligoclonal banding came back positive, but that took a couple of weeks. She had an MRI of the brain with gadolinium, and she actually had another one after about 2.5 weeks. And both of them essentially were the same in that they didn't show any kind of inflammation, any abnormal white matter signal, any stroke, any hemorrhage. The main thing that they showed was really quite evident cerebellar atrophy. And I know not many of you look at cerebellums on MRIs that often, but it is pretty small here. It's kind of all these little tiny branches. Usually that will be quite a bit thicker, even in the midline. So you do get the sense that this part in the posterior fossa is quite small, whereas the rest of her brain looks really quite normal. She had a SPECT scan of her brain, and there actually they noted on the SPECT scan, so nothing really supratentorially abnormal, but atrophy of the cerebellum 3.8, so almost 4 standard deviations below expected normal. So really quite striking atrophy of her cerebellum, which was a little odd in that, the story was that a few months ago, she was totally normal, like had no problems with her balance or anything. And just in these last couple of months, started to have all these problems. So had a pretty broad workup in the hospital. So we did CT angiography that didn't show any kind of signs of vasculitis or any other arteriopathy. She had pan scanning, so CT thorax, abdomen, pelvis, and then afterwards a repeat MRI of her abdomen. She had some hemangioma in the liver, but nothing looking like any malignancy. She had bilateral breast ultrasound to look more carefully for a potential breast cancer. She had ultrasound of the pelvis with no findings suspicious. I think there was one lung nodule, small lung nodule, that looked pretty innocent, with recommendation of follow-up imaging in 6 months. She had paraneoplastic, paraneoplastic and autoimmune encephalitis panels sent from her serum and from her CSF that eventually came back all negative. Again, they take some time to come back. She had HIV and syphilis serologies that were negative. She had PCR for HSV, VZV, CMV from her PCR, all negative. Antibodies for tissue transglutaminase and gliadin, looking for like celiac-related ataxia. Thyroglobulin, thyroperoxidase, steroid responsive encephalopathy, all came back negative. B12, vitamin B12, vitamin E were normal. Copper was normal. The metabolic things all looked okay. So we weren't quite sure what to do with this lady, but so we went with basically a working diagnosis of paraneoplastic cerebellar syndrome without kind of antibodies. And without a cancer still. So very uncertain, but clearly something was happening progressively to this lady. So she had pulse of corticosteroids, followed by an increased oral dose of prednisone, and also after that, a course of IVIG 5 days. And thought there was maybe a little bit of improvement, but she was kind of hopeful, but it didn't really seem like there was any objective real gains. So she was in the hospital for a couple of weeks, 3 weeks roughly. Eventually, with things fairly stable but not really improved, she was discharged. And then I got a bit of extra information because she actually shortly thereafter presented to another hospital. And there she had some additional workup, including a PET scan, again, negative for malignancy. We've not been able to find any signs of any malignancy, but they did also do a repeat lumbar puncture and tested for JC virus, and that came back positive. As I said, she had 2 MRIs a few weeks apart with gadolinium, no white matter lesions whatsoever, so no features typical of progressive multifocal leukoencephalopathy, which is the usual CNS brain manifestation of JC virus infection activation. But what she really had is a different type of JC virus brain infection, you could say, or manifestation, which is this granule cell neuronopathy. So granule cells are one of the subsets of cells in the cerebellum. And so JC virus activation, I think most of us know, a common in immunocompromised, well, not that common, but certainly happens in immunocompromised patients. And usually it affects their oligodendrocytes and causes this PML. So these sort of large, diffuse white matter lesions, often throughout the brain, they can have a lot of be sort of mass-like, cause a rapid sort of deterioration in cognition and focal deficits, and it's often quite terrible, devastating, progressive condition. But there is also a JC virus infection, and usually sort of seen with actually a mutant JC virus. It's a variant that they think the mutation gives it altered tropism for the granule cells, so it will infect cerebellar granule cells and then causes this rapid cerebellar atrophy. So over the course of weeks to months, you get very rapid cerebellar degeneration with really not much effect on the rest of the brain. So patients with this infection basically present with this progressive pancerebellar syndrome. So classically ataxia, dizziness, dysarthria, occurs over weeks to months, exactly the clinical picture that this lady unfortunately had. So the risk factors typically are thought to be, this is quite rare, so much more rare than PML, which itself is not all that common, but has usually the same kind of risk factors. So we think of, PML in patients with HIV infection, with hematologic malignancies, or with chronic immune suppression, and usually the sort of heavy-duty immune suppression. For the granule cell neuropathy, it's been described with rituximab, with natalizumab, gets used a lot in neurology for MS. The kinds of things that you will see PML, similar list, a wider list, but immunosuppressing medications associated with PML. So far, I could only see really one sort of similar description in the literature. So about 5 years ago, there was a report of JC virus granule cell neuropathy in a patient with SLE described as mildly immunosuppressed. I don't know, I didn't get the whole details of that article to say exactly what kind of immunosuppression they were on, but we don't normally think of, azathioprine, Plaquenil as being sort of heavy duty to cause PML, to cause this kind of trouble. But I think that picture all really fits. I think it is the best explanation for this lady's presentation. I just want to bring that case forward because I thought it was quite interesting, and I learned, actually, I really must admit I was not aware of this granule cell neuronopathy. I don't expect everybody to, think of that first thing when people have ataxia, but more the bullet point, I think the third one was just that old adage to keep in mind of, immunocompromised patients, keeping the differential broad, right? Trying to consider all the possibilities. And so, yeah, my miss on that one was I didn't look at JC virus in the initial LP. And then going back to the earlier points, so stroke patient cohorting, as you'll see more patients, hopefully with acute strokes on 3D when the ISU is full, which it usually is. And then in future, you may see them eventually on at Centenary as well, on the 5th floor. And the last point, the status epilepticus. So keep in mind that lorazepam, so Ativan and Dilantin, lorazepam, phenytoin, still tried and true first line, very effective therapy for status epilepticus. So I know often many of the patients that present to us, emerge as seeing them first, or, but sometimes it is, they'll have a second seizure or they'll go into status on the floors. And so sometimes, medicine, we are the ones treating the initial phase of status. And so phenytoin and lorazepam and phenytoin, actually in that order, lorazepam, then phenytoin, still, I think, is the most reliably effective second line therapy for dealing with status. So I will stop there if anyone has any questions. If not, enjoy the 19 minutes left in your hour.
Oh, hey, Dr. Smith, I have a question. It's Loretta
Sure.
here from pharmacy.
Oh, hi, Loretta.
Hey, thanks for sharing the memo. So I also shared it with the pharmacists at all three sites, and one of the questions that came up was, okay, so if a patient was maintained on Keppra PO at home, and then for whatever reason they have to be NPO in the hospital, do you feel comfortable for the MRP or for the pharmacist to recommend temporarily being on IV Dilantin, or is it something that requires a neurology consult to make that temporary switch? Because in ICU, like the NG tube is inserted almost at the same time as they're being intubated, but maybe on a medicine floor, it takes a bit longer for that NG and the G tube to be in.
Yeah, I wouldn't do that as like an auto substitution. So patients stably on Keppra, they can't get Keppra, and then to just like load them with Dilantin as a temporary measure, I wouldn't necessarily suggest that. I think that's a case where if there's a short period and there is a parenteral option for levetiracetam, that's a fair use of it. I would generally try to get, I think, an enteral route as quickly as possible. But yeah, I wouldn't suggest saying, oh yeah, if you're on any of these other things, just like give them a load of Dilantin and they'll be fine.
Okay, thank you so much.
You're welcome. In the same way that Keppra is not a panacea, Dilantin is also not a panacea. Okay, well, thanks everyone for your attention, and see you around.